My name is Lynn Coatney, and I'm a CRPS mom. I've been on the board. I was on recently, came on recently, and I have to do that. And I'm so glad to be a part because RSDSA was our lifeline when Laura was first diagnosed. It gave us that fantastic information to take to the emergency room or the dentist, and gave us a lot of things to read about and to learn. So I'm glad to be here, and I've learned a lot today. I have the pleasure of introducing another board member, Dr. Joshua Prager. He's a Harvard and Stanford trained physician, and he has 4 board certifications, including internal medicine, anesthesiology, and pain medicine. He has many accomplishments. Dr. Prager is a former faculty, Massachusetts General Hospital. He's the founder and former director of the UCLA Pain Medicine Center. He served 2 years, 2 elected 2-year terms, as chair of the International Association for the Study of Pain's CRPS group. He organized 2 international CRPS symposia. He has 3 awards for CRPS and his contributions by patient organizations, and has published numerous articles and textbook chapters about CRPS. He's trained 100 fellows in pain medicine in the last 30 years. He was the first physician west of the Mississippi to administer ketamine infusions for CRPS at the encouragement of Dr. Robert Schwartzman. He's done over 8,000 infusions. He runs a comprehensive interdisciplinary functional rehabilitation program for CRPS. Let's bring it up for Dr. Joshua Prager.
Thank you very much for that generous introduction. It's really a pleasure to be here. I think others have asked it, but I'd like to know, how many of you are CRPS patients? And how many of you are caregivers? Oh, it's about an equal mix. Well, I thank all the caregivers for being here. Needless to say, CRPS is something that's near and dear to my heart. I've been caring for CRPS patients as a major part of my practice now for 30 years. And the interesting thing about my involvement with CRPS is that, as mentioned, all these fancy places that I went to school, where I did residencies. I finished all my training, an anesthesia residency, an internal medicine residency, medical school. Never once heard the term reflex sympathetic dystrophy, which is what it was called then. And it wasn't until 4 years after I completed my training and I started doing full-time pain medicine that I saw my first, quote, RSD patient, and it fascinated me, but it also bewildered me that I could go through all that training and never even hear about this syndrome, which now we think of more as a disease. Never heard of it. And so it was 1991, and I go to the library to look at articles, because in 1991 you couldn't go look for articles on the internet because we didn't have it yet. And so I got covered with dust and started wheezing a little, being in the stacks of the library. And I found an article by Dr. Robert Schwartzman, who, by the way, I dedicate this lecture and my contribution to this meeting to Dr. Schwartzman, who passed away. But I called him on the phone because we didn't have cell phones to do that. And Dr. Schwartzman answered, and he was very generous in his time with me, and from that point on became a mentor from afar, that whenever I had complicated questions about CRPS patients, he would he would answer the phone and talk to me about them. And he was very generous to me. The other person who has been very generous to me is a physician named Michael Stanton Hicks, who is retired now from the Cleveland Clinic, who also had a major experience in CRPS before I started, and from afar was able to give me advice when I needed it. So all the lectures, well, I shouldn't say all the lectures, but many of the lectures today have been about how to do things. And this lecture, I think, is kind of a fun lecture because with my experience in CRPS over the years, I've run into things that I never hear talked about that I think everybody who has CRPS or is a caregiver for a CRPS patient should know about, that I think can enhance life or, more importantly, prevent problems. So this is the meeting, and the name of my practice is the Center for Rehabilitation of Pain Syndromes. Now, it's an interesting name for a practice. Rehabilitation, not cure, but rehabilitation. Get people to the point of remission, get people to be functional. And we have a functional rehabilitation program that our largest referral source is the workers' compensation system in the state of California, because we have such a great record of getting the CRPS patients back to work. And more than 50% of the patients who come to us for the rehabilitation program actually go back to work. We say, Dr. Prager, 50%, that's not a really good number. But when you compare what it would be, which is way less than 20%, we feel we're accomplishing a lot, and they pay the money for it because they don't have to pay somebody's salary the rest of their career. This is the little agenda that we have for today. Did the introduction. The next thing I'm going to talk about is assistive devices, then the impact of surgery, the impact of childbirth, the effects of trauma, impact of low oxygen tension of flying in altitude. You've heard a lot about bisphosphonates, so I'm not going to belabor that, but I'll talk about it for a minute or two. And I think what I'll say is very consistent with what Drs. Hardin, Brule, and I think Dr. Moskowitz said, and completely in contradiction to some of what Dr. Chopra said. To talk a little bit about how new technologies impact things, a few words about ketamine, and then a little bit about choosing a provider. So assistive devices is a passion for me. And first thing I just want to do is show you something that you shouldn't use. Now, I'm not saying you should never use a crutch, but is there a pointer built into this thing? Whoops, that wasn't it. Okay, right over here, you see this? If you have CRPS in your foot and you have that pushing on your brachial plexus or the nerves in your armpit, you can wind up with CRPS in your hand by irritating those nerves. So there's a solution to this. I'm not saying not to use a crutch, but here's a device. Do you see the padding? Now, where did I find it? The padding up here, and I'll show it better in the next slide. This is cushioned, so although it provides you support, it doesn't cause any irritation. And this is called a Moby crutch, and just other things about it. It has a handle that is very sturdy, that allows you to take weight off, again, without putting weight on your armpit. And then also about, at the floor, it's very substantial. So if you're going to use a crutch, you want to use a crutch like this. And I cannot tell you how many patients have come to me over the many years that wind up with CRPS in their hand spread from their foot because they were using that hard crutch. Now, just a word about wheelchair, and I know a lot of people here are in wheelchairs, and my goal in my practice is never to have anybody in a wheelchair. And we really work hard to prevent people from, if they are deteriorating at the beginning of the time, that we see them, not to get into a wheelchair. But I think this walker right here is the one that I recommend a four-wheeled walker rather than the one with the two legs that hit the ground, and people always put tennis balls under them because they make horrible noises. But the advantage of this over a wheelchair is it does, when you're not doing that well, it still encourages you to walk when you can. You can sit on it, and it usually has a storage, I can't see this one, but usually has a storage place underneath where you can put some things in. But more important, you can sit on it when you need to sit on it, and people can push you around on it some when you need to be pushed around. But the name of CRPS, if I can emphasize it, is use it or lose it. And the less you use it, the worse it gets. We see that especially when people are in casts, the CRPS can get worse. When they don't do things, it gets worse. And there are some of you in wheelchairs, and were you my patients, I would be working with you to get you out of the wheelchair, to give you more of your life back. And that's my goal. So, words about surgery, and this is now getting into things that people don't tell you, but when you have surgery, any trauma can cause CRPS to come back or get worse. And surgery without prophylaxis, without preventing the stimulus from the surgery to get to your spinal cord, can create bigger problems than even the reason for the surgery. So we have a whole prophylactic regimen that we use to prevent the surgery from affecting the patient, so that when you have, let's say, you want to operate on the knee and you don't want to get CRPS up your whole leg, which is what we see when there's not prophylaxis. Now, we see this also from dental procedures and then just from general trauma. But general trauma, you can't prevent general trauma, but surgery is a controlled form of trauma that's impact on the nervous system can be prevented by regional blockade. And that gets us to childbirth. And one of the things that I'm proudest of in my practice, and also it's kind of an interesting demographic, because I heard here today several people say that CRPS is most prevalent in women, which I agree about. But they said from 60 to 80, I think something, or 60 to 70, 50 to 70. My population is mostly women 20 to 40. I mean, I have teenagers, I have pre-adolescents, I have people in the Medicare age group, but more than half of my patients are women 20 to 40. And I don't know if that flies in the face of what everybody, well, it does fly in the face of what everybody else is seeing. But if you're a woman between 20 and 40 and you want to have a child, then you should be able to have a child. And the thing we have to think about is that if you have a traumatic vaginal delivery and you need, let's say, an episiotomy, you can wind up with CRPS in your vagina. And then you can never have sex for the rest of your life. So we recommend C-sections in a very controlled fashion, and we've had 100% success, and that's a big number, 100%. You never should say 100%, but we've had 100% success when following our protocol of not developing CRPS that bothers the patient as the result of childbirth. And one of the things I'm most proud of in my practice is my album of babies of CRPS moms, who many of whom probably could never have had children if they didn't get their CRPS better and if they didn't go through this. And it's one of the most meaningful things to me in my practice is having that album. So the other thing is just trauma. And here's a motor vehicle accident, which is a very common problem that we see causing exacerbation of CRPS. Let's say you have CRPS in your ankle, and then you bang your shoulder in a motor vehicle accident, and you can wind up with CRPS in your shoulder. The good news is that if you get to somebody that really knows what they're doing right after the accident or right after the trauma, you can prevent the CRPS from spreading. And that's really important, because that's almost like a different disease. When there's trauma with old CRPS, it's like fresh CRPS in a certain way, and all of us who treat CRPS know that if you get it early, you have a really good chance of getting it better. Now, unfortunately, with the retirement of Dr. Schwartzman and Dr. Stanton Hicks, I get the patients who've seen 7 other pain doctors over many years, and they're much harder to treat than a fresh case or a potential recurrence caused by trauma. So if you have CRPS and you get in a motor vehicle accident or you sprain your ankle or whatever you do, make sure to get to somebody that knows what they're doing right away and get medicated and not opioids, but medicated in other ways to be able to block the CRPS from rearing its ugly head again. I failed to mention also about with surgery, one surgery that we see a lot of is dental surgery. And minor fillings, they don't really require anything, but if you're going to have like an implant or an extraction, we have a prophylactic regimen from that to prevent CRPS from spreading to the face, which we can see. And I think it's really important that you do that kind of prophylaxis so that you don't wind up with CRPS in the face, because that CRPS in the face is not a pleasant place to have it. Okay, so another topic is low oxygen. Now, when you fly on an airplane, any distance, you're flying at an altitude, the air pressure is equivalent to 6,000 feet, which is higher than Denver. Okay, now, we know that smoking makes CRPS worse. And why does smoking make CRPS worse? It's because the carbon monoxide that comes out of the cigarette that goes into the blood binds hemoglobin to form what's called carboxyhemoglobin, which doesn't carry oxygen. So less oxygen to the tissue until the 90 days when that red blood cell winds up deteriorating and out of your system. You have to, well, the best thing is not to smoke. And I can't tell you how many patients that have gotten so much better in my practice just by me getting them to stop smoking. So we know that low oxygen causes problems. We also know probably that, although Dr. Chopra said that hyperbaric oxygen has no impact, there are quite a few articles in the literature that demonstrate that hyperbaric oxygen for some cases of CRPS can be beneficial. But it's not really strong literature, but I can tell you that my patients with non-healing wounds, where I can get the insurance company to pay for the hyperbaric oxygen, they get the hyperbaric oxygen for that. The CRPS tends to get better with it, and we actually published case reports about that. That I'm not recommending hyperbaric oxygen, but I'm just telling you high oxygen probably can help, and low oxygen in a plane is a bad idea. So if you're flying from, let's say, Dallas to Georgia or something, to Atlanta, that's a short flight, don't worry about it. LA to Portland, probably don't worry about it. LA to New York, yeah, it's probably too long at low concentration. I had a patient who had he had CRPS and he had twin daughters at Boston College, and he'd fly from LA to Boston, get off the plane, and he couldn't walk, even though his CRPS was mainly in remission. And so the solution was this gadget here that I saw with an old guy with lung disease on a plane. This is FAA approved. It concentrates oxygen out of the air. It's with a battery supplied, although it can plug into the cigarette lighter adapter too. But it allows you to function at what essentially would be room air at ground level, so that you don't get your CRPS activated by low oxygen. And certainly, I used to, when my patients would go to Europe, I'd have them carry oxygen tanks with them to do that until I saw this gadget. The FAA requires you to have 2 batteries in case one dies, and that's not because of CRPS patients, but it's because the lung patients, if all of a sudden the battery dies and then they're in the air with low oxygen, they could have a fatal event. Yes? I should have put it up. The name of the company that I've had the best success with is called Inogen, INOGEN. Gen, but there are many. They're a little more expensive, but they have a lot of nice features, and my patients have found them to be very dependable. And if you're flying to Europe, you definitely should be doing it. If under 3-hour flight, probably not important, but once it's over 3 hours, what does that say? It weighs 2.9 pounds. You spend an extra $100 and they give you a really nice case to go along with it so that it has the batteries and the hoses, the tubing for your nose.
It's lighter weight than some of the other models.
Oh, it's also really sturdy. Well, I went hiking at Machu Picchu and was hiking up to 13,000 feet, and I'm no youngster myself, and I bought one of those and went hiking with it and made it a lot easier for me. Anything else about oxygen? Oh yeah, I'll just go back for a second. Denver's not a great place to live in if you have CRPS. I've had 2 patients move to Denver, and well, one of them wound up getting that gadget, so they would use that gadget all night, and that seemed to be enough. The other one moved to Hawaii. And for whatever reason, in my practice, it seems that moving to Hawaii is probably the best place to live if you have CRPS, if you can afford it. What was that? You had a comment?
For your lifestyle.
Right. So you've heard a lot about bisphosphonates, and I'm not going to belabor a point. I think the studies where it didn't get approved were flawed, and I had done consulting, as Dr. Harden had done, for the company Gruenthal that were doing the studies, but they really didn't want to listen to what we had to say. And there's another study coming along that I think my office will be participating in, and you won't have to pay for the noradrenate, and you don't have to go to Italy. I should just say a word about, any of you think about going to Italy to get noradrenate? Oh, no, only 1, 2? Was it one of these medical tourism companies that were trying to bring you there? And they'll put you in a first-class hotel and have a limousine drive you all around, and they'll make
I don't know about the limousine, but yes.
Yeah, they're for-profit places. With the availability during these studies, they'll be able to try noradrenate. And it's not for everybody. That's the important thing to recognize. There's a subset of CRPS patients that it'll be very, very beneficial for, but the reason that it didn't get statistical validation is when you give it to all comers who have CRPS, you don't get enough of a statistical signal to show that it should be able to be FDA approved. So, newer technologies. This is something we see different things showing up all the time. And this one in particular is the scrambler, and somebody mentioned it. How many of you have used a scrambler? Not that many. How many of you used a scrambler and it continued to provide you benefit? No hands up. 1, 2. Well, good. We've tried it in my practice, and the first patient did spectacularly well for a few months and then didn't, and the next 10 patients it didn't help them at all. But if it works for you...
No, it only worked for a couple months.
Oh, okay.
I went back to do another thing.
Okay, that's the story that I hear everywhere. And there are offices that'll charge you several $100s per treatment and want you to do like 20 treatments. It's a lot of money if it's not going to work. But there are new technologies that come along all the time, and I just suggest that you critically look at any of them. 15 minutes, got it. I'll have time for questions. That you critically look at anything before you use the technology, but we're seeing all kinds of things. My philosophy in my practice is that if it won't harm a patient, let's try it. And I usually tell the company that has the gadget, I don't want to pay for it until I see it works. Let me use it in my office for a month and see. And unfortunately, usually it doesn't work out. Ketamine, you've heard a lot about ketamine, and Dr. Schwartzman called me on the phone about 20 years ago with his accent, and he said, Josh, you're not going to have a CRPS practice unless you start doing ketamine. And that inspired me to do ketamine. And as I mentioned, we're 8,000 infusions later, and it is an effective therapy in the properly selected patients. One patient came up to me and told me about her situation. And I said, I wouldn't use ketamine on you. I don't think you need it. It's not for everybody. When you have a major flare, we find it to be very effective in just quieting it down. Like, again, after a motor vehicle accident, you're getting all stirred up. We can find it effective. There are certain cases where you need to stratify the population to see if it's going to work. And we always do a short trial before we get involved in real therapy. And Dr. Schwartzman recommended 20 consecutive days. From an insurance standpoint, that's not feasible. So we do 10 days of treatment, and we find about 50% of the patients get, most of the patients get about, if they went through a successful trial, they get 3 months, and then at 3 months, about half of them need boosters, and half of them don't need more boosters. So ketamine is definitely effective for CRPS. There are numerous articles demonstrating its efficacy. I think Dr. Harden and I were on one of those articles that reviewed the literature on it. But ketamine can work, and in my practice, occasionally it's like a miracle. I mean, the interesting thing is sometimes it doesn't make the pain go away, but it makes the suffering go away right away. And so the patient will say, well, the pain feels the same, but it doesn't bother me as much. Well, that's half the battle. If it doesn't bother you as much, then you can go about your life. So I really very strongly believe in ketamine when administered properly, and Dr. Tropa made a good point, is that it should be done by people that know what they're doing, who do it in a safe way in the proper facility, not somebody doing it in their office in a chair. No good. Okay, so the last thing is about choosing a provider, and I'm probably not telling you anything new, but the internet is very powerful now with reviews, and US News and World Report, WebMD, there are just a bunch of sites that evaluate doctors. And that gives you at least a glimpse of who might care, who might spend time with you, who everybody else thinks is a good doctor, and who people think are not. And you want to stay away from that latter group. So you want to do your research about a doctor before you go there. And you may want to, if the doctor's willing to interview you or you interview the doctor briefly on the phone to get an idea, that's a good idea. But not all CRPS providers are the same, that's for sure. And you want somebody that not only has the knowledge and the skill, but that really cares about you. And it's really, really important. So that's my talk. Thank you very much for your attention.